ended up taking him over to CAT scan. And when we got him into the CAT scanner, we laid him flat. I could see it pulsating in his abdomen. And I was like, oh, that's not good. And so I went in and talked to him. He's still very lucid, carries on a full conversation with me. And so I told him, I said, I said, this is what's going on. And he says, well, what are we going to do? And I said, there's really not much we can do. And he says, so I guess it's the end of the road. And I was like, yeah, it is. I said, we're going to do what we can to keep you comfortable. And he says, okay. And that was the first time that I've ever had to tell someone that they were dying and there was not a damn thing I could do to stop it.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and I have got a great episode planned for you today. Now, before we get started, if you haven't done so already, please take the time to leave a rating and review for the podcast. That helps other people find this podcast. And always, make sure you share this episode with a friend. You have some advanced practitioner friends out there, and they're going to dig this podcast, because my guests today are Ben and Tom from a podcast called Just Some Podcast. The full name is Just Some Podcast for Advanced Practitioners, and it's hosted by Ben and Tom. They are hilarious. Oh my God, we had so much fun recording this episode. I got a chance to meet them last year when I did the Nurses PodCon, and oh my God, we just hit it right off. I had an opportunity to be on their podcast not that long ago. They were kind enough to host me there. And this time it was my turn to get them in the hot seat. So you are going to love this episode with my friends Ben and Tom from Just Some Podcast. I hope you enjoy this episode. Oh, and keep in mind that the thoughts and opinions shared on this podcast belong to me and my guests alone, and they don't necessarily represent our organizations, places we work, places we volunteer, our friends, our family, whoever the case may be. They are our opinions only and should be taken as such. So keep that in mind. Enjoy the podcast. All right. So first, gentlemen, I have the two gentlemen, Ben and Tom, from the Just Some Podcast for nurse practitioners. And I'm going to let you guys introduce yourself. Who wants to go first?
So my name is Tom. As Mr. Kevin has said, I am a family nurse practitioner in the state of Ohio. I am in a small practice, but in a earlier former life, I was an ICU nurse, and then I made the better decision, left the dark side, came to the light, went into the ER, where I was for several years, ended up as a trauma program manager and a stroke program manager, and then I became an ER supervisor. And then I decided to finish school. So that's kind of the long route to where I'm at now.
Nice. Sounds like similar paths with me, with the exception of the nurse practitioner thing. So
yeah, it was a long road to the middle. That's what I like to do. So
there you go.
Well, I'm Ben. I'm a board certified family nurse practitioner. Also, I'm in the state of Kansas, and I actually started as a brand new RN day one in the ER on Memorial Day weekend because I'm insane.
Yeah, terrible.
Yeah, it was
bad timing. Bad timing.
But it definitely was a trial by fire. But it was great, and so yeah, I have a bunch of ER experience, and then I was an ER provider for a while. But now I kind of focus on family practice and doing that. So
that's awesome. Anyways, so both of you guys got ER background. Both of you guys went on to be family nurse practitioners in different states. Did you guys live in the same state? Like, how did you guys, have you guys been friends for a long time?
So we've actually been best friends for 20 years, probably. He actually lived down here where I lived, and that's where he started his ER and ICU and stuff was down here. And then for whatever insane reason, he decided to move to Ohio, and so he's up there now. So yeah, when we do our show, we do it all over the internet.
Nice. Now, who became a nurse first?
I did, yeah.
And then did you encourage Tom to go become a nurse after? What were you doing at the time, Tom?
I was a police officer, and Ben was a dispatcher at the CAT county and I was with the city. And honestly, when I first found out he was going to school to be a nurse, oh boy,
You razzed him.
yeah, I was like a male nurse, Gaylord, and like I could not stop myself. It was pretty constant for a while, and then he started working the ER, and so then I'd go out. The smaller hospital didn't have their own security force at the time, so if anything happened, we had to go out there. So I saw Ben pretty regularly out in the ER, and getting to know him, getting to know the staff, getting to know the other ER nurses, and seeing what they did. And a few tragic events later, I decided I no longer wanted to be on the other side of the fence and went to school and became an ER nurse myself. So that's he never really encouraged it. I think mostly because of the verbal trauma I gave him from becoming one himself. But I'm super glad I did. He did, however, I will say this, he did encouraged me to keep going. Once I became a nurse and I was like, I want to keep going, and I got my bachelor's, and I was like, dude, and I was like, what courses should I do? What should I learn? He's like, just keep going. Just
Good for you.
School and go do your thing. And at first I kind of resisted for a couple years. And then one day I was just sitting there and I literally just looked up some information on a school, and bingo, bango, I became a nurse practitioner. So that's pretty much what happened.
Nice. Oh, that's kind of cool. It's kind of cool when you have friends who are like encourage you and like go further, keep doing this.
Well, speaking of ER stories, actually when I first applied to nursing school and I was still a police officer, I was out there as a police officer, and I was talking to this retired Navy personnel that had become an ER physician, and we were talking one day, and he's like, I was like, I think I want to become an ER nurse. I'd really made the decision. I'm really considering it. And honestly, the final straw, hadn't broke yet, but I was right there, and I was like, he's like, you don't want to be a nurse, all this other stuff. I was like, I don't. He goes, no, because some asshole like me, that's what his term, not mine, is gonna say, hey, go do this, this, and this, and you are gonna just bristle at somebody ordering you around. And he goes, I don't know if you want to be an ER nurse. And I was like, I'll show that jerk he's wrong. And then, kept on going. But thank you, Doc, for that little words of encouragement. But yeah, that's like actually the first ER nurse talk I got was before I even was in school officially yet. So.
That's funny. I was in the ER as a tech for a long time, and was trying to figure out what I was going to be when I grew up, and decided that I thought about nursing for like a second when I was, just finishing high school, and I was like, I want to be a nurse. Like, I don't want to do what those guys do. No way. Never did I know anything about emergency nursing. And then once I did, I was like, oh, yeah, this is kind of cool. It's be all right. So my goal actually was to be a flight nurse. And then I never met that goal. My goal changed once I finished nursing school, but yeah, it was one of those where I was like, you don't think of ER nursing is not like what you think about when you think about nursing or nursing school.
100%.
Yeah.
100%.
Yeah. So.
And I actually wanted to be a flight nurse as well. And then my body stature changed that dream for me. So, it's like the same thing here.
I was going to say the exact same thing. It must just be an ER nurse thing. Like, that's the next evolution. Like, oh, I want to get my flight status too. But yeah, I like tacos too much. And gravity, I am gravity resistant. I don't know what the current term would be, but I am very not flight worthy. I'm not aerodynamically stable. I don't know a lot of words we can go with.
When I kind of looked into it, they were like, yeah, you're going to have to lose some weight. And I was like, well, I'm probably not going to lose that much weight. But who knows? And then, it was kind of funny. When I did lose weight not that long ago, I told my wife, I'm like, I'm almost the size that if I want to be a flight nurse, I could. And she's like, you're almost the size where you can be divorced too. So just let me know. Just let me know what you're thinking there. She's like, no, flight nurse. I don't think so. And the reality is as cool a job as it looks to be, it's probably not for me. I got as close to one of those, those life-changing crashes as I ever want to be. And, I lost a couple friends in those at times, and that's enough for me to be like, maybe not.
Yeah,
so.
And all the praise to you guys, but I'm at the age now where waking up at 2 a.m. into very cold conditions to go, I'm like, nah, I like sleeping now.
Yeah.
I'm lazy and soft, and I want to stay that way. So
Yeah. It's as you grow, your dreams change, and you're like, that'd be really kind of cool. And still, you think, that'd be kind of sexy and kind of cool. But then you're like, yeah, I'm not sure that that's for me. So, Ben, why nursing?
Oh, well, I was a dispatcher, like Tom had said, for the county for 911, and I'd done that for quite a few years, and had just gotten out of a relationship and was just kind of toiling. Didn't really know if I wanted to stay in that or what I wanted to do. And my mom's a nurse, has been a nurse for 20 some years. And one day she sat me down and she said, you have the intelligence for this. You have the compassion for this. Just go do it. And so I was like, well, not doing anything else. So sure, why not? And so I applied for nursing school. Didn't get in my first time because I had kind of screwed off my first semester of college and, had the C's. And so my GPA was low. So I had to redo those classes. But once I got into nursing school, it was just something opened up, and it was like, oh, this is what I'm supposed to do. This is where I'm supposed to be.
Was your nursing school competitive to get into?
Yeah. There's usually, at that point, they were taking 25 students, and you'd probably have 120 to 200 apply.
Wow. Holy cow. Yeah.
I went to the same school, and it wasn't much different for our class. I think we had maybe a bigger class, but roughly the same numbers.
Yeah, we had when I applied to nursing school, it was you show up on this day, you apply, and it's kind of one thing they tell you is they're kind of like, okay, you got to get good grades and this and that, and really the reality is the way they do it was those good grades are going to get you there to that point, but then when you get to that point, it's first come first serve, and the person who's in line first gets in first, and which is not the ideal way to do it, of course. I don't think they do that anymore, but it was like one of those, like if you have a GPA, if your GPA is solid and then it's just kind of, you get on the list. So people would, I would always hear about people showing up at like 6 o'clock in the morning, getting in line to try to get in this class. And, I went to go sign up for it was my day to sign up for the class. So I got there early that day, and I worked at the community college where I went to school. So I got there super early, and the head of nursing one goes, so are you applying today for nursing school? I said, yeah. And she goes, okay. She goes, our thing starts at 8 o'clock, and there were already a couple people in line. And I was like, yeah, this is like 7 a.m. And she's like, why don't we just sit here and take your information down so you don't have to get in line? I was like, yes. Absolutely. So sure enough, she took my information. She's like, okay, she goes, you'll be in next semester. And I was like, that's incredible. So it worked out, and I've never regretted it. I've never regretted becoming a nurse. It's been, I always tell people it's one of the best decisions I've ever made. The ultimate job security you have, the variety of things you can do, the potential income you can make. There's no choice like it. So,
no, agree wholeheartedly.
Now, Tom, what made you decide to become a nurse practitioner?
Well, honestly, it just seemed like the natural progression. I did not start off with this grandiose idea, and I hear it so often now from young people going into nursing. Well, I'm going to just go straight through and get my nurse practitioner, and blah blah blah. And I'm like, how about you try being a nurse? I actually, and this is something we say on our podcast all the time, I actually still miss bedside nursing, so I don't want anybody to think I don't enjoy what I do now, because I love being a nurse practitioner, but I also don't want anybody to think it's this progression where you lose touch with that side of you. I think any of us that go into getting our master's to become a practitioner, we don't lose touch with that bedside part of us. And basically it was just over time, like I said before, every time I did something, I wanted to learn more. I wanted to be better at my job. Really, that's really what it was. It wasn't a great idea, I'm going to serve mankind. It was just the next time my doctor says something, I want to know what he's talking about. And that learning led to more learning, which meant, and so on and so forth. And finally one day it was, hey, time to go get your master's degree and get board certified. So do that process, and kind of that's how I ended up here. So
now, what are your thoughts on people that do that I always jokingly call it zero to hero, right? So they go from associate degree, maybe bachelor's degree, to right into a family nurse practitioner program or right into a critical care nurse practitioner program. What are your thoughts on people making that jump?
And let me be real clear. This is my personal opinion. And
Yeah.
I have interviewed some very prominent people on our podcast that disagree, that they think it's okay.
I have to. There's a handful of nurse practitioners that have been on the show, and a couple of them were like, hey, it works for med school.
Yeah, it does. I'll tell you, here's the thing though. I disagree with it myself. And there's several reasons why, but the primary one is an APRN is an advanced practice registered nurse. And if you never spend any time as a registered nurse,
yeah, you don't have that base.
You don't have that base. And honestly, one of the largest criticisms we get from physicians is lack of hours and lack of training. But the whole idea is that we have this great nursing knowledge and this great working base that we are simply building upon. And when you delete that evolutionary step, you are taking away a large foundation of experience and knowledge that they can use to help take care of patients. So me personally, I am pro, I wish there was a movement where you had to have so many hours as RN before you could make that graduate school decision. And again, it's nothing against people. I know there are surely there are great nurse practitioners and physicians assistants, that went straight to it and they did all that stuff.
Yeah.
But I gotta be real honest. There is so much that is intangible. I can't tell you what you're going to learn, but I know you're going to learn it. Taking care of people that are sick in an ICU or an ER that you can then apply to your practice that is invaluable, and they're going to miss that experience just because they can. And I think that's a disservice to them and their patients. But that's me.
One of the things I find, and I always, I admire, I've been an ER nurse for so long that sometimes I forget that it's not all ER nursing. But I remember when I was a house supervisor, I remember working with the nurses on the floor and the med surg nurses or the SAC or the ICU nurses. And for SAC is subacute care. For those of you that maybe call it step down or whatever. I remember thinking to myself, as an ER nurse, you're always like, oh, whatever. Those guys don't do much upstairs. We know that's not the case. I'm just, talking smack here. But sure enough, I remember being impressed going, oh man, they take care of a lot of stuff. They'll call the doctor. I worked in a facility where the doctor wasn't there all night. And they were the eyes and the ears of the doctor saying, hey doc, I need you to do this. I want you to order that. And they were kind of not calling the shots, but they were certainly helping direct the care. And it gave me a whole new respect for some of the med surg nurses that maybe I didn't have as much before. And just showed how great of clinicians some of those folks were. There's people who've been a nurse 20 years and, been there, done that. They've seen it all. They've done it all. And those guys know how to take care of patients.
They certainly do. And I floated for a short period of time between ER supervisor and then ER working the floor. And yeah, it was a whole new jungle to go into some of those floors. And I really did defer. I never went in with the whole, I'm a hotshot ER nurse. I don't listen to you. But man, yeah, because there was times I was like, I don't know what is going on. This is stadium because I was used to my chaos. And
yep.
ER is chaos. I think it's a controlled, organized chaos, but it's certainly that. Versus the other types of nursing, the med surg and ICU, you cannot have chaos. You can't, because if you do, then the machine breaks down.
Something's going on.
So yeah, I do tell everybody, when they talk about, I'm like, ICU, other than, the specialty like labor and delivery and stuff like that, really ICU and ER are opposite ends of the spectrum. They are completely
very different. Yeah. And there is a type, right? There is a type for ICU and a type for ER nurses.
And honestly, I think if you, at the end of the day, if you really want to take care of people and you're willing to learn, you can go anywhere.
True.
But I think in your character, some people are more suited to ICU and some people are more suited to ER. I was an ICU nurse at a level 2 trauma facility. I had a great time. I learned way more than I ever thought I would learn.
Yeah.
And even though I was dead set on becoming an ER nurse, I learned to appreciate and value that time in ICU more than I could have. But at the end of the day, I'm an ER nurse, and that's what it is. So.
Yeah. And Ben has joined us back. He had a very important phone call.
I'm the deputy coroner, and so it was actually a coroner call. So I was trying to
People are dying to get you off this podcast. Is that what you're saying?
That's what I'm. Yeah.
Wait. Hi, so a nurse is a deputy. Okay, that's like a whole other episode. Like that could be kind of interesting. Yeah. So I'm going to leave this part in the podcast. I was teasing you, and I was going to cut this out, but now I'm going to leave it in. And if you want to hear about being a deputy coroner, is there interesting stories? Would there be an interesting episode there?
Probably.
Well, I'll ask Tom. Tom, does he have some interesting stories?
Oh yeah.
You're like, yes, make it an episode.
Yeah, of course.
Well, you were talking about those, crashes with like flight nurses, and so I mean that's what. That's what I do is I go out to that. So. Yeah,
you're like, oh yeah, those people are too dead to be here. We take care. Okay, that's gonna be okay. So I am going to just do this little call of action in the podcast. If you want to hear that kind of episode, leave me a comment. Leave me a comment on social media, and we'll see if we can get Ben to come back here and talk about seeing dead people. We'll make it the Sixth Sense episode.
I like it. Yeah,
I see dead people. My very first episode of this podcast, there's a young lady who was on her very first clinical shift and seen a guy who got hit by a train. So, and it's kind of funny. I was thinking about this. She was the very first episode of the podcast because her story has always stuck with me. Like she was one of my EMS students a million years ago. And I got to talk to her this weekend, and we were like, she's like, hey, you know what? Some trauma has come up. Like I realize I'm feeling a kind of way about it, and I want to talk to somebody. I'm like, let's talk. Let's have that conversation. And we did, and it was fucking awesome. So, but yeah, like it's different, right?
Well, I think there's something really therapeutic to what we do.
There is.
I think not just talking about it, but listening to other people that have been through something similar. There is this catharsis that happens where you're like, oh, I don't feel so bad. And that's one of the things I tell my patients when I treat people for depression is that one of the insidious things about trauma and depression and anxiety is it can make you feel isolated. It can make you feel alone. And that's how it gets you like that. And so a podcast like yours is just fantastic. And, I love when we interview people because we're telling a story and we're putting it out there. And it made me really excited to come on your show and talk tonight. So.
Yeah, it's been a lot of fun. It's been a lot of fun. And sometimes people will say, this feels like therapy. you're like, great. You're going to
involved. Yeah.
You're going to get a bill. You're going to get a bill. I'll send you the bill soon. But speaking of patients in your past, Ben, I'll punt to you. Tell me about a patient that changed the way you practice. A patient that changed the way you practice, when you were working in the emergency department, particularly.
I had a elderly male that had come in. And I was a provider at the time, so I was the provider for it. And it was a small little level 4 trauma center. So, I mean, it was just like a small facility. And he'd come in earlier that morning for like respiratory asthma, COPD type symptoms. And we'd give him a breathing treatment, had done well, was able to ambulate back and forth down the hallway, got his oxygen up, did great, sent him home. And or sent him back to the nursing home, I believe it was. And then 8 hours later, I hear Paige go out to the nursing home, and it's the same guy. Comes back in. I'm like, okay. And they said he was unresponsive. So then my first, immediately I'm like, well, did the albuterol, in my head I'm going, well, did I do, that's your first thought is, did I screw something up?
Yeah.
And when we ended up taking him over to CAT scan, and when we got him into the CAT scanner, we laid him flat. I could see it pulsating in his abdomen.
Oh,
I was like, "Oh, that's not good." And CT confirmed, he had a ruptured aneurysm, and so we bring him back. And I pulled the family aside and talked to them. And they said, well, what can be done? And I said, not much. I mean, I said, if you want bells and whistles, I can call a helicopter. We can fly them out. We can do whatever. I said, or we can go the other way and just go comfort measures and go from there. And so I went in and talked to him. He's still very lucid, carries on a full conversation with me. And so I told him, I said, I said, this is what's going on. And he says, well, what are we going to do? And I said, there's really not much we can do. And he said, so I guess it's the end of the road. And I was like, yeah, it is. I said, but we're going to do what we can to keep you comfortable. And he says, okay. And that was the first time that I've ever had to tell someone that they were dying and there was not a damn thing I could do to stop it.
Wow.
And so, I mean, it resonates with me. Moving forward, you're like, oh, because you have those conversations with families after codes. Mm-hmm. But to physically have it with somebody who's actively dying while they're completely lucid is just,
yeah, like this isn't going to go well, and there's not a whole lot we can do that's going to change that.
Yeah,
what a hard conversation to have. Holy crap!
And you see, stuff on like movies and stuff, where like, oh, the guy's, got pinned by a train, and as soon as they move the train, he's going to bleed out, and they sensationalize it, and it's not sensational at all. I mean, it really isn't. I mean, it's a horrible conversation to have.
And there's nothing sensational about that.
No.
So, and that's sometimes a hard conversation to have. Like, to be like, yeah, there's a couple things we can try, but there's probably not a whole lot that's going to help.
Well, like I told him and told the family, I said I can transfer him, but I can't guarantee that he'll make the transfer. Yeah. I said, and then he's going to die in an ambulance on the way, or in a helicopter or whatever. Yeah. And they all kind of made the decision that no, they didn't want to do that.
Yeah, because I almost think for the family, like what's better, like knowing that you have limited time, but you get to sit here and visit, or saying, hey, you know what, we're going to put him in a helicopter and see how it goes. Yeah. You're like, shit, that didn't work out, and you wasted those last precious hours.
Yeah.
So that's a tough question, man. Like I'm not sure. Like, and I'm not sure. Like, if I was in that as a patient, I'm not sure what I would want. Like, I don't know. I'm not sure. Do you want to go for the fix, or do you want to go to the be like, had a good run, it's worth a try. Like, what do you think, Tom? What would you do? Would you opt to make those extravagant? And I say extravagant measures. There's it's not super extravagant, but.
I think honestly, I would probably, being the provider, being in that case, I'd probably do a bend it and say, here's the options. But I don't want to say I'm known for. That sounds bad. I'm not very flowery. Like, if something sucks, I'll just be like, this sucks. I have a lot of diabetes patients that have heard the words, your A1C sucks, coming out of my mouth. So I think at a time like that, clarity, and that's another thing, and this goes back to my ER days. This goes back to my police days, is when the stuff's hitting the fan, we don't want to have a long conversation. Right?
Yeah.
You got to get to the point. And I think at that time, you go, what do you want to do? But you lay out the facts very clearly. There is a very real chance you die alone if you get in this helicopter. However, you will die if you stay here.
Yeah.
It's funny, but I mean, that's the spot you're in, man.
Yeah.
I can try and save your life. Me personally, I'm looking at it as, me now. I'd be like, you put me in the bird. you get me to the hospital.
You go find me a good surgeon.
Yeah, but I don't know. I don't know if I'm 80. I don't know if I'm 80.
And that's
the call. I think at 80, I watched my grandkids raised. I've seen what I'm gonna see, and I can say goodbye to my wife to her face.
There's a lot to be said for that.
Random dude who's sitting with his crotch in my nose, because birds are real tight spaces. So I'm just.
It's a good point.
That's what you get.
It's a good point.
I think 80-year-old me goes, I've had the good ride. I've done the thing.
Yeah.
T-shirt. That's what I do. But
yeah,
I don't know. I've had tough conversations, both as a nurse and, as a provider. Sometimes the nurse ones were hard because you're not the final word, but they're looking at you, and you're the one in the room with them.
And you're the one who's gonna take the time to have that conversation. Like the doctor may or may not take the time to have that conversation. And sometimes I remember in one case the doctor coming in, and then the doctor walked out, and I asked the guy, I said, "Did you catch any of that? Like, do you understand what he said?" And he's like, "No, not really." I was like, "Okay, let me translate here for you."
Yeah, I've had to do that a couple of times, and yeah, that's one of the things I remember, and Ben reinforced me, is when you have big news for a patient the first time, is especially like, let's say the first time you tell someone they possibly have cancer or they do have cancer.
Yeah.
There's really not a lot to talk about. After you say the word cancer, like mine shuts off, just like in an emergency in the ER, whether you're talking to the family or the person that got out of the car wreck. If you wouldn't be like, well, it's going to drizzle, so we can't fly you this event. No, man, you're bleeding. I'm stopping your bleeding. And then I'll talk to you once we get past that, you got to keep it simple. So I think at that time, that's a tough spot. I don't know what to do if you're in it. So
Yeah.
I think if it's a young guy, you do the full court press. I think if it's an elderly guy, you go, okay, which way do the dice roll?
Yeah, which way do you want to go? I remember when my mom was dying, and I remember I very specifically remember having a real conversation with the doctor who's like, she's 70 something and she has emphysema and she's a train wreck. She's on 6 liters of oxygen every day now, right? And now she's short of breath. Like, what are we going to do here? and as tough a conversation as that is to have, we then had a conversation with somebody who didn't know her, didn't have a relationship with her, wasn't her long-term care provider, who came in and who told my family. Didn't even tell me. They told my family who was there, saying, "Well, why aren't you guys intubating her? Like, why aren't you guys intubating her? Why aren't you guys doing everything? Why aren't you doing everything to try to save her life?" And I was like, "Fuck you! Like, look at her. Like, what are we gonna do? And having that awkward conversation of then telling my family, like, they don't know what they're talking about. Like, listen to her doctor, and her doctor said, DNR is the right call. So,
and that's yet another conversation that is hard to have, but I think it's absolutely necessary.
How do you start that conversation? How do you initiate that conversation? Because for a provider, it's probably a little bit different than it is for an ER nurse. The ER nurse is like, stand by, I'm going to get you the provider. Hold on 1 second. I'm going to go get you the doctor or the NP. But you guys actually have to be the ones to then have that conversation and start that.
It depends on, in the clinic setting, when, they're in for their wellness exam, Medicare exam, whatever, that is a great time to talk about it because they're not in that acute situation where things may change their mind.
Of course. Yeah.
And so it's a very simple conversation, at least for me, is, hey, if something happens to you and your heart stops or you stop breathing,
what then?
Put tubes down your throat and do you want them to do your chest compressions? And the vast majority of patients say no. I say, well, then, okay, I need you to sign this. And that's what this is saying, is you don't want all that stuff.
Yeah. Well, God bless you for having that conversation.
The first time I was actually part of one of those conversations, I was the prop. A patient was not doing well. The ER doctor was in there trying to explain to this family why this person should be a DNR.
Yeah.
And they actually called me in the room. It was not my patient. I had nothing to do with it. And the doctor's sitting there, and she turns and she points at me, and I'm a very large person. And she said, "This is the guy who's going to be doing CPR on your grandmother who's not going to make it. Are you telling me you want him?" And she went into detail about, what happens. And I know it sounds crass, but at the same time, I think that they could not put a picture of what was going to happen.
Well,
providing that picture, suddenly I'm very real. 300 pounds, a beard, standing there covered in tattoos.
Good.
People go, I don't want him on name, snapping his ribs in half.
Good point.
It was a very like, oh, they'll do CPR, and they've never seen CPR. So.
It's a very different procedure than what we see on TV.
Oh, absolutely. Yes. And of course, everybody listening to this obviously probably knows that, but that is a stark reality of TV have no idea, that doesn't make a good drama.
Do you
stopped? Yeah.
Do you remember the first time you did CPR, Tom?
Well, yes, but again, the first time I did CPR was actually as a rookie police officer. Nobody told me that the ribs broke.
Oh yeah, me too. Yeah, first time. No one ever told me.
I'm helping, and all of a sudden just heard that. I said, the way I explained it, it sounds like an atomic fireball left in the wrapper and then step on it. I was like, that pretty much is what it sounded like.
Yeah.
But my first time in the ER was as a student, and I was doing rotation somewhere else, and they called a code, and me and another male student weren't doing very much at that point in time. So we were
like,
in the ER, and they
come on, you're gonna be the muscle. Yeah.
Yeah, they just had us doing stuff, and the guy came back. We got Rosk, and we walked out of the room, and we were just, to make it better. And Ben can validate what I'm about to say. So me and this guy were walking out. We were in labor and delivery for students. We're wearing the surgical blue scrubs, right? We're walking out. Some girl runs up to us, goes, "Excuse me, doctors." We didn't say we were doctors. We just stopped and turned around. She goes, "I think you left your cell phones down here." We're like, "Those aren't ours." And just walked off. So we never said we were doctors. We just did tell her we weren't doctors. And oh my God, the other classmates, which were all female, wanted blood. Like they're like, they got to go to a code. They got called doctor. We were like, oh boy. But yeah, that was the very first time. And I got to be honest, I hadn't done it very much. Most of the time I did it for a couple minutes until EMS got there when I was on the street. So
Yeah.
I didn't have a lot of experience with it. And after that first time, I was like, what's the big deal? I just went in there. I just pumped on this guy's chest like a couple times. He came right up. I don't know.
Yeah. It's just like TV. Like
clearly you guys have been doing it the whole time because it just took me and Sam to fix it. So that's what happened. So yeah, it was very misleading. I had this grandiose idea that I could just touch your chest and you'd come back to life.
You're like I'm good at this shit.
I'm really good at this. Yeah.
That's funny. Ben, do you remember the first time you made a Midair?
I don't remember a Midair. I remember we had a patient with 4-point restraints that the doc had ordered Haldol on, and I remember going into her leg and hitting her femur with the needle. Inadvertent. I mean, it wasn't intentional.
I know, but I could just see his face like, oh.
Yeah, that's that like you're like, oh,
right.
That,
can you imagine that?
Yeah, it just dead stop.
And you know there was a nurse standing by him going, yeah, that's the femur.
yeah, you did well. Yeah, you got it right in there.
You're a little past the muscle.
That's not an IO there, Ben. Yeah.
Then I remember mixing up TPA one time for a stroke patient, and I get it all mixed up, and I'm walking over to the patient, and the doc walks in and says, and I mean, like I'm ready to like screw it into the IV, and he's like, "Don't give that." He's like, the hospital transfer to doesn't want that given, and I was like, right there with it, ready to go, and didn't get to give it, and I'm like, wow, I just wasted $6,000. Like that's insane.
Yeah, it's expensive. The good news is if you mix it and don't give it, they'll usually comp you one.
Oh, we'll see. I hope that
they'll give you a free one. They'll be like, it's fine. Do you, Tom? Do you remember a time when you were giving a medication where you're like, okay, this is a little intimidating? Because TPA is one of those meds. TPA is one of those meds that's kind of intimidating because you're like going, okay, 30% of the time, even if this all goes well and we do everything we're supposed to do, they're still going to bleed out. Like I guess probably not 30%, probably like 20% of the time, but you can do it all right and the patient can still die.
Yes. So actually, I got two stories about first time I gave drugs that stand out. The first one was the first time I gave adenosine, but I don't think that's unique. I think every ER nurse has that story.
Yes.
I do distinctly remember screwing it on, like checking it, like yeah, and everyone's like, just push it, like come on,
just go.
Let's go, and I'm like, this is really scary, and I'm turning my head, and there's like 4 nurses like rubbing their hands together, like, oh yeah, let's go, let's get this going, and I'm like, oh boy, so that's the first time I remember pushing something that I knew was going to scare me.
Yeah,
like that was it. But
and they tell you, hopefully they told you, okay, now watch the monitor.
Watch the monitor.
Watch them on. Don't. This is one of the few times that you don't have to watch the patient. Someone else do that. You watch the monitor.
Yeah.
No proof.
And you're like, okay, there it is.
Yeah, me and the ER physician actually held our game really long on that one. Like, oh, thank God, yeah. But no, I had an elderly male patient back of the ER, intractable back pain, and this new young doctor. This was several years ago. Okay, so when I say the word ketamine, that wasn't a standard thing that was really out and about at that time.
Yeah.
And so he's like, "Hey, let's try giving this ketamine." I was like, "What do you mean try? Right? We're not going to surgery, doc." Like, I was basically telling him to get lost. Like, I ain't doing this. And he's like, "No." Like, I mean this. Me and this doctor had a really good relationship, and he was really basically talking me into it. Like, no, if I do this, we could. It wasn't. I know, and it wasn't like it was intimidation. It's just we had that relationship, and he wasn't like straight up ordering me, because I told him I have got some grave concerns about giving this dude ketamine. And not only did I check the dosage, I made him check it. I made the pharmacist come down and check it, all three of us together. I'm like, oh no, if I'm going to push this for pain medication, I want to know what's about to happen. And this guy was just like in pain, but he was so nice that he cussed, and it was like, damn. And he actually, I'm sorry for speaking like that. And I'm like, is this guy for real? And his wife's like, oh yeah, that's how he is. I'm like, okay. When we pushed that ketamine, he started panting, and of course I am starting to fill my pants, because I'm like, oh, here we go. Like, this is going downhill already. And then all of a sudden, I will never forget, after about 30 seconds, all of a sudden, he started snapping his fingers like he heard a beat that nobody else could hear. And he literally said, "Hey, Daddy, that was some great music," or something. He said something like that, but it was like, "Hey, Daddy-o." Like, I was like, what the hell is going on? And his wife is about to pee her pants. She's laughing at this guy. She's never seen him so high in his life. And I saw it, but that sheer panic of watching him start to go crazy, and I'm pushing a drug I'd never given. Ooh, yeah, that was an experience I did not enjoy. It turned out great, but man, that was just 30 seconds of abject terror. I was like, oh, I don't like this. Yeah, it was not fun.
It's kind of funny because when I was an EMT, before I became a nurse, as an EMT, we had this scope of practice where we can give these meds, we can give it these ways, and you memorize that. And I remember in nursing school going, okay, like, what's our scope of practice? And they're like, everything, you name it. Like, if there's a drug, you get to give it. And, there's some that you need some training on, but for the most part, like, if you can pull it up, you can give it. Like, if the doctor orders it, you're going to give it. And when you think about that, like, there's no way to like study for every drug on the planet. You just got to have to use, good common sense in your 7 rights or 8 rights or 10 or 12 or 20 rights, whatever there are now. And yeah,
like I said, I was not being aggressive. I just was standing firm. I was like, until this ER doc and this pharmacist in front of me confirm I'm giving the right amount of stuff and all this other stuff, I was like, I ain't pushing nothing.
Yeah.
I'd made a early decision in my life, even before I became an ER nurse. There are just certain things I will walk out the door. Like, I got my baseline. I'm not going off this, and you ain't moving me. So that's how I live, day to day. And I was like, I'm not pushing nothing until I see some numbers, and they provided. So I did it.
There you go. Okay.
Story. It's not about an intimidating medication, but it was about a medication that I learned the correct dosage of post using the medication.
Okay. It's always, sometimes life gives you the lesson, then the
ER doc, and I was still a nurse at the time, and he'd used a Tomidate, and very short acting, and he had a lady who had a dislocated shoulder, and we pushed the medicine. She falls asleep mid conversation. He's like, "Tell me about your horse," because she got bucked off a horse, and she's like, "Oh, my horse is," and then just out, and reduces the shoulder, and 4 or 5, 6 minutes later, she wakes back up mid conversation, just right back where she was. Like, my horse's name was or whatever, And so I was like, this is a cool medicine. So 2 weeks go by. Now, I've bragged to EMS about how great this medicine is. They're here. We have a 16, 17-year-old female who comes in with a dislocated elbow.
I got this.
So I'm like, oh, accommodate. Great stuff. Yeah. By the way, it's 0.3 mgs per kg in case anybody out there is checking the math. Yeah, to this day, remember what it is. It's not 0.1 mg per kg. 0.1 mg per kg of etomidate will get your patient intoxicated, but not fully asleep. So I pushed this med, and I'm assuming, I mean, obviously I had orders to do this because I was the ER nurse, and so I'm assuming the doctor I was working with just wasn't familiar with the medication, or, you know, as far as like the dosage or whatever the case may be. I don't remember that part. I just remember pushing medicine, and she doesn't go to sleep. Nothing. And I'm like, well, that's weird, because like it worked great on the last one, you know, just out. And so I go out and I drop some more medicine. I'm like, well, you know, which is a very short acting drug, as I said earlier. So I come back in and she is just giggly, laughing. And I vividly remember, I can even tell you what room she was in. I vividly remember walking back in and she says, "Are you a parking ticket?" And I kind of look at her and I'm like, "What?" And she's like, "'Cause you got fine written all over you." And I was like, "Whoa, what?" Like, of course,
you, my friend, are intoxicated.
EMS is just rolling laughing. Give her some more medication. No, it's like it's just not working, you know. The orthopod, who's known for being not the nicest guy in the world, comes walking in now, and she's still intoxicated because we've given her kind of enough etomidate to just, you know, keep the intoxication level going, apparently.
And now he's got to figure out what else to give.
Yes.
To put her down.
So he's like, so she's like, "Excuse me, do you like blueberry or strawberry pancakes?" And he kind of looks at her weird and he says, "I guess blueberry." And she's like, "Okay, I just want to know what I need to make in the morning." And he looks at me and goes, "Put her the fuck to sleep." I was like, we tried. So we end up calling anesthesia down. They give her Dipperman. And she's like, "Oh yeah, they've already tried to put me to sleep. This isn't going to work." And he's like, "Oh, that shit does." But yeah, knocks her out. They get her elbow fixed. And so as the anesthesiologist leaves, he's like, "When she wakes up, tell her I won." Like, okay. And so we, you know, pass it along to her after she woke back up. 4, 5, 6 years later, still working in the ER. This couple comes in. We're talking to him. It was the guy that was being seen. His girlfriend was there with him. And she walks up to the desk and she says, "Do you remember me?" And I'm like, "No." And she's like, "Parking ticket." And I was like, "Oh my God, yeah, I definitely remember you, yes." So, etomidate, 0.3 mgs per kg, in case you're wondering.
Now you bring up a couple points that I think are worth kind of talking about. Like, I don't know if your town's a small town, but we see these patients over and over again. Like chances are you're going to see these patients again. And I know that you know, as a nurse practitioner, that's what you do, right? Like you build relationships, long-term relationships with these patients. But in the ER, it's not the way it's supposed to go. But sometimes it does, right? Like sometimes you see the same people over and over, and you're like, you know, I always think of a girl named Rita. Rita would always come in for the same thing. And I'd be like, "Hey, Rita, how you doing? How's it going?" Well, like, "You're here more than I am. And I'm here a lot." But you see these same people over and over, and you're like, wow. And in a small town, it's an even bigger deal.
Oh, yeah.
You know, when you're talking about you see people so much, I remember one time they ordered Toradol for a patient. That was a frequent flyer. And I walked in there and they told me how much Toradol was in the syringe. I said, "Oh, that's a 3 ml syringe. And you're at half a mil, so you're at 30 milligrams of Toradol." I was like, "You are here way." Oh no, she swear to. I was like, "You are here way too much," because I had to actually stand there and do some math. She knew the size of the syringe and the volume of the fluid. That when I told her the drug, she knew how much she was getting, and I was like, "Wow, that's impressive." I'm not gonna lie. I was very like, "Lady, okay."
Yeah, you're like, yeah. When you're that much of a frequent flyer that you know what you're getting and how much you're getting and what it means.
Yeah. That's the thing about frequent flyers, and I always train my new guys or new girls. You know, I don't want them. You know, one of these times they're gonna be sick. Okay, so that's the crap.
Sure.
Is you can't ever. Now, granted, if they're there for like knee pain and they're walking around and dancing in the hallway, you're like, okay, get back to your room. I get it. But when you got that frequent flyer, it's always coming in for chest pain. That was always my fear. Is one of these times, old Cindy Lou is gonna have actual chest pain, and I can't afford to not.
Yeah, it becomes the boy that cried wolf, right?
Yeah, and so that's always. I get it, and we all see the same. And I feel like, especially if you've been in the ER for a while, you get that feel for what's going on. But I never want to lose that sense of this can get away from you. The minute you think I know everything, the universe will definitely pull that rug out from under you just to prove to you how much you don't know. And I just never wanted to find out that way. So,
but talking about being in a small town, and I would see patients out at Walmart, grocery stores, or wherever, and I used to tell people, and I told them it was a defense mechanism of some sort. I don't know. I didn't look at faces like when you're in the ER, unless the injury or whatever that was directly involved with your face. I didn't look at faces, and I told myself it was a defense mechanism because we're treating friends, people we know, things of that nature. So you'd see people at Walmart, and you'd be like, "Hey, you took great care of me in the ER," and I'd be like, "Okay."
That was nice.
Yeah. But then if they would start telling me like what they were in for, or
like,
give me some clues to it, and then I'd be like, I could tell you everything we did and what room they were in.
Yeah. But
to look at faces, I just never did. Like, I would take care of people that I knew and not realize it for several hours.
Yeah. You're like oh.
Up to like admit them upstairs. I'm like, oh shit, I didn't realize it was it's I don't know. It was a weird thing I did.
Yeah.
I don't in family practice now because you try to build a rapport in that relationship, but ER, you just, that was one of the things I said was, you're only here for a few hours and you're leaving one of a few ways. Either you're going upstairs, you're going, home, out on a helicopter in a body bag. We're not here to build relationships. I'm here to fix you and make you better. And
I always joke that I'm a short-term relationship kind of guy as an ER nurse. I'm like, I don't want a long-term relationship with you. If we have a long-term relationship, that means you are here way too much. But you'd still see, you'd see frequent flyers all the time where you're like, oh, that's Dave. I know Dave's social security number. Like I can get him registered. But you, whether you want to or not, you end up building relationships with these people. And you're right. There's sometimes that you'll see somebody. And I remember a family member saying, hey, I remember you taking care of my son, years prior. And I was like going, gosh, I hope I was nice to him. And she goes, actually, you were kind of mean to him. And I was like, I was like, oh, wow. Okay. And she's like, oh no, he had it coming. He had it coming. Like he needed the rough, he needed some tough love and you gave him some tough love. And I was like going, gosh, I'm glad you felt that way. Because if I was giving him some tough love and you didn't understand that that's what maybe needed at the time, then you just think that's a big old jerk. Yeah. And this was, this was before, Press Ganey was really a thing. I mean, the hard part about patient satisfaction in the ER is the people who get our surveys are the people we probably give our least good care to.
Oh yeah.
Right. Like they're not the ones who were saving their lives. They're not the ones that were making a huge difference and catching these amazing things that are wrong with them and sending them upstairs to get better. No, they're going to get an ICU survey or they're going to get an IMU survey. We're going to get, Joe, whose stitches we had to remove. And he had to wait, 10 hours for that because we were a really busy day that day. Yeah. So
Bill was here for a seventh time trying to get hydrocodone because, he's out.
Yeah. So it makes it a little different that we don't get to give our best care to the people who are going to get our surveys. So. Hey everybody, Kevin here. I hope you enjoyed part 1 of this podcast episode. Part 2 is going to be coming to you next week, so be sure to download it for even more Ben and Tom, and I think you're going to like part 2 even more. Have a good shift.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.